Hello everyone. Today we are going to be talking about the other CV drug. CV just stands for cardiovascular. So this is also part of the cardiology module. So let's just get into it. It's kind of a grab bag. So that's what's here on this title. There's going to be things that are going to help with angina or pronounced angina, either way. My professors always said angina, so that's what I usually go by, but you can technically pronounce it either way. It's like tomato, tomato. Cholesterol medication. So this can be a big section here. Definitely want you guys to pay attention to that. And then some heart failure drugs. All right, just a little bit of review. Probably going to get this in pathophys and some of your other courses. Just make sure everyone's on the same page here. But basically, when there's not enough oxygen supply, a lot of things can happen, but there's pain that can happen. So angina pectoris is a chest pain. And it's just basic take-home point is that there's not enough oxygen supply going to the heart. So what do we do with that as far as pharmacological approach? These are some different drugs that you can use to help with the angina. Some of these you guys will probably remember from other presentations, right? Specifically, we have a lot of these that were covered with the antihypertensive lecture. So definitely, again, with categorization, for my test, make sure that you are keeping all the categories straight. So like calcium channel blockers is one that we've already seen now. They're antiarrhythmic, they're used for antihypertensive, and now they're antianginal. So make sure you keep those straight. And then which ones of the calcium channel blockers can be used, for example, to help with arrhythmias, and which ones can help with hypertension, and then which ones are good for angina, right? Same thing with the beta blockers. So again, the reason I'm stressing this is just because students in the past have had some problems keeping everything straight. And I know, and it was the same thing for me too as a student. When I first came, I had zero experience. Never been in a pharmacy, never, stepped foot in a clinic or whatever. It was kind of crazy. I got into pharmacy school without any healthcare experience, so that was lucky, knock on wood or whatever. But because of that, going to pharmacy school, everything was brand new to me. So these categories sometimes I'd be like, wait, I thought this was for hypertension, because these drugs I just had never, it was all a foreign language to me. But anyway, so please keep these categories straight. Goal is to reduce pain, right? And basically increase oxygen supply. So, or a couple different ways. You can either decrease oxygen demand or increase oxygen supply. But again, there's that deficit of oxygen. And so how do you overcome that deficit, right? Again, just kind of background FYI, pathophys, don't stress too much about this, but it's just to make sure we're kind of given a good picture, good overview here. First and foremost, we have the nitrates and nitrites and nitrates. Said that backwards, but nitrites and nitrates. These are very similar chemical structure. Kinetics, pharmacokinetics, you guys probably know by now. I don't have you guys stress too much about this, but look at this, read through it. It is interesting in that the kinetics of the medications affect how it is manufactured or in what products they have available. So you'll notice like one, for example, nitroglycerin, they have a transdermal, they have a patch, an ointment, and they have sustained release tablets. So it is good to know kind of your toolbox, so to speak, when you're prescribing, when you're out there practicing, and when you're on rotations too. And so, just don't stress about memorizing this for the exam, but definitely pay attention to it and make note of it. It's not bad stuff to know and learn. It's not, but I always have students like, hey, I won't necessarily explicitly have you, what are all the forms of nitroglycerin, IV, sublingual, et cetera, But it also to note which ones are rapid acting, which ones are long acting. Again, that'll come more into play, not explicitly for my test, but that will come into play when you're prescribing and what you're giving. So nitroglycerin, if you want a fast acting preparation, make sure you're giving it sublingual or IV, right? So this is something that you may have seen family members, I don't know how big your families are or whatever, or what kind of ailments they have, or maybe out in the clinic or whatever, where the nitroglycerin have it's a tiny little dark glass bottle, a little vial that carries the nitroglycerin sublingual tablets, because those are very rapid acting. They absorb in the buccal cavity and in the mucosa of the mouth, right into the bloodstream, and then you get that quick action of nitroglycerin. So, again, just think about these things as far as when they'd be appropriate to use and to prescribe. And I'm pretty confident you guys will get this on rotations as far as when these come into play, and when you see them in what settings. Mechanism of action. So take home point is vasodilation, right? This is going to involve nitric oxide. So anytime you see nitric oxide, I want you guys to start making the connection and thinking about relaxation of vascular smooth muscles and vasodilation, vasorelaxation, etc. So that's something that hopefully you guys will be making that connection there. And this is kind of a continuation of what I was saying, but go ahead and read through this. But note here dilation, right? The vasodilation. So basically, that there's that oxygen imbalance, and this helps it correct by redistributing the blood via vasodilation, right? And here's a good visualization if you like visual guides. Don't stress again about memorizing this, but this could help you when you're studying for your mechanism of action. So this is kind of optional as far as how much time you want to spend with it, but I like it. And again, like I said, I like visual stuff. It's just these things stick in my mind, and I can kind of pull them out in the test or out in practice or whatever. But so you'll notice where some of these things are working, and kind of what they're helping. Either are they increasing oxygen supply, or are they maybe helping with oxygen demand? What are they doing? And then here they're listed here. So nitrates-induced vasodilation. I'm going to read through that, but you can notice that there's just a lot of different things that it's doing to basically help increase, the oxygen supply, and then hopefully help reduce the pain. It's funny today. I even have my windows closed. Sorry, I got to vent here a little bit to you guys. I even have my windows closed, and it's like people are like, we live kind of near a parking lot, but they just come and like turn their motorcycles on or whatever, like rev their engines right outside my house. Come on, people, I'm trying to record here. But anyway, so yeah, apologies for all the crazy. I try to anticipate it too. I can kind of see some people. I'm looking out the window, but other times just like random hot dogging. I had one of my dad's uncle would always call it hot dogging. But anyways, okay, that's not on the test. So yeah, read through this and make sure you understand. But take on point again, vasodilation is the big thing. Interesting too, they can be used for erectile dysfunction, ED. I don't know if you guys remember. Shout out to Bob Dole. I don't know if you guys remember him. You guys are probably too young. He had those commercials where he had ED. But he's an old politician, just in case you guys don't want to Google it. Anyways, we're going to talk more about these in the GU module. And so don't stress too much about it now. I mean, definitely look at these. I want you to know which drugs are listed in here, but we will be revisiting these. And then just note too, for drug interactions, when you're giving nitrates, definitely put a star by here. You should not give other vasodilators. And the reason is hypotension, right? So with too much vasodilation, it can actually be a bad thing. So in a pathological sense, vasodilation can be good, right? Because it can help reduce the angina, etc. And there's just some other benefits too. We talked about that with reducing blood pressure, but in combination with other vasodilators. So definitely put a star by that. We're going to mention again, you'll get that again in lecture, but I definitely, for testing purposes and stuff, want to make sure you guys remember that. And it's one of those drug interactions that kind of falls through the cracks because people or practitioners, and this is experienced practitioners too, sometimes aren't mindful of that. There's a couple different things that can cause vasodilation, and then what are the implications of that. So anyway, so that's one that we monitor for in the pharmacy and stuff when we try to catch you and help you guys out, right? You're welcome. No. And then also note too that you should stop taking these drugs if you have either vision or hearing loss. Okay, another hot rod group or something. I don't know. Sorry about that. Always not messing with auto too much. Also note too that sildenafil has a different brand name. So if we go back on here too, I forgot to mention the name: sildenafil, tadalafil, vardenafil, and those are more commonly known by their brand names. So that's Viagra, Cialis, and Levitra, right? Those are the ones those are usually what they're referred to by their brand names. And then that kind of segues to the next one. So sildenafil, which is generic for Viagra, has another brand name. So sometimes this happens in the FDA, or rather drug companies, will apply to the FDA to get patents on their medications, right? And they'll have a brand name. That's why I put the little registered. It's a registered trade or whatever, not a trademark. That's TM, but registered name, and depending on their indication and use. So there's a few drugs. It's not super common, but there are a few drugs out there. So Viagra is one of them, where depending on the brand name, you can kind of get an idea of what they're supposed to be used for. So Revidio is the brand name for the for sildenafil, which is generic Viagra. It's the same chemical, but it got an FDA approval for PAH, pulmonary arterial hypertension. So that's what's note on there. As usual with my testing purposes, for me, don't stress about the brand name, but just definitely note that. And it is something that has, it has been confusing for students and stuff, because you usually just think of one brand name, one generic. But so Viagra, Revidio, and sildenafil are actually all the same thing. As far as when you write your prescription, it is beneficial if you write the brand name, maybe even if you want the generic, or this would be an instance, I guess, where, so if you're going to prescribe generic sildenafil, I guess I should say it this way, Texas pharmacy law does not require that you put an indication on your prescription when you're writing a prescription. If you feel like it's not in the best interest of the patient, or whatever the legal law says exactly. But take home point, you don't have to write. So you don't have to write sildenafil is for ED or so. But if there is a medication, and this happens a lot with some of the psych drugs, if there's a medication that has multiple uses, so if it's something like, we talked about the clonidine recently, right? So clonidine has a ton of different uses. So it'd be nice with something like clonidine or something like sildenafil, if you are going to prescribe it, to put what it's used for, or its indication rather, because that would help us in the pharmacy. Because sometimes, like with clonidine, it affects which is appropriate dose or inappropriate dose, or it can affect the insurance and billing, etc. But so sildenafil is another example of that. And it's considered best medical practices. So you're going to be hearing that out in practice and out in your facilities and stuff on rotations. And basically, best medical practices are things that aren't necessarily explicit in the law, but then they are something that have been found to be beneficial and that can kind of be helpful when practicing medicine. So you'll occasionally hear me mention that. Seriously, there's like some dude who's just like circling the block, I guess, with this like crazy engine. The other day too, there's this guy with this muscle car that was like working on his car outside the parking lot where we live. But all right, so I'm sorry to keep getting distracted. I'm trying not to let it bother me, but obviously it is, right? Sorry. Okay, so here's some guidelines too to talk about when maybe sildenafil should be appropriate for pulmonary arterial hypertension, or PAH. Just go ahead and read through that, and then just know that it is something that can be used for that as well. Other uses of nitrates, and why we're talking about, is angina, right? Angina pectoris, angina atax. Also can be used for heart failure, which we'll talk about some other heart failure drugs here in a little bit, sometimes in combination with other medications. This is another one that we will talk about later, which we had seen in antihypertensive too, right? And then also in the hypertensive emergencies, right? Which I would please go back to my other lecture that's specifically on hypertensive emergencies to see kind of where they fit. Adverse effects. So common adverse effects are headaches. Definitely something people complain about and stuff. Usually they're transient, so they usually don't stick around. And so they're usually not a big deal. And you typically don't need to prescribe something to treat that headache. So unfortunately, sometimes in medicine, you do have to prescribe a medication to treat an adverse effect of another medication, but that's not considered best medical practices, or that's not, it's something to avoid, because then it's like, so you prescribe something that gives headaches, and then you prescribe a headache medication to treat the headache. Well, then that headache medication has adverse effects, and then you have to treat something, and let's say it causes constipation. I'm just making this up. Causes constipation, so then you have to prescribe a laxative because the person's constipated, and then that laxative, what does that cause? Electrolyte abnormalities? I don't know. Again, just kind of making this up, but you see this out in practice sometimes, where you end up, the saying is like a dog chasing its tail. I don't know if you guys have heard that. Some people say that, right? That's a common thing. But it's like you end up becoming a dog chasing its tail with your prescribing something to treat something that's an adverse effect, etc. But most common adverse effects are CNS adverse effects, so headache, dizziness. The hypotension's there, and you definitely need to pay attention to it. And especially in combination with other medications that can cause hypotension, right? So hopefully you guys are starting to kind of build your toolbox, so to speak, and you're starting to make these connections that will, because again, at the end of all of these courses, the goal is that you will be able to make these connections and pull from, because we're at the last section of pharmacology 3, we're going to be talking about some medications that can cause hypotension, and you'll have to pull back to your first semester, and you'll be like, well, I don't remember anything from when was that, but so anyways, and then the flushing too is one that's not super common, but it's annoying, or rather, that's unprofessional to say, right? No, it's patients find it uncomfortable and they don't like it. So it's not super common. It's like 2% or whatever. It's not, but it's one of those that if it happens, patients may want to discontinue the medication. On the less common one too, reflex tachycardia, that can happen, but something to be thinking about. And then the anemia is something that is a rare but serious one, but that's something that can happen. The other thing too, in related to elderly population, is that related to the CNS depression, it may also, that it can be, increased fall risk, and then with hypotension or bradycardia too. Again, not that you can't use it in elderly population, but to be cautious with an elderly population because of those CNS adverse effects, and with the CNS depression specifically, right? Tolerance is occasionally an issue, and we'll talk about that with certain drugs. So the nitrates are one that you do have to worry about tolerance. So they sometimes cannot be used long term. It's just basically your body compensates to the way that they're working. So go back to mechanism of action, and then just basically note that the body can overcome that mechanism of action is kind of the take-home point there. So the good news is your headache disappears, right? So you can see that on the slide, but the bad news is the medication stops working or whatever. And then that also too can affect how you prescribe it. And so like with the patches, you may have to have a patch-free interval is what they say, what the textbooks call it. Patch-free interval. It sounds so official, but it just basically, means take off the patch, for certain times or whatever, or you'll have it certain days you'll wear the patch or not. But anyways, and that's related to the tolerance. Next, we have the beta blockers. I almost said beta blockers, but beta. Sorry, my Oklahoma roots are coming out. Beta blockers. Get her done. No. Okay, so beta blockers. We'll see them again. We've seen them in antiarrhythmic presentation. We saw them in the antihypertensive presentation, and we're seeing them again. So again, as far as categorization, please keep these all straight. Mechanism of action, you guys already know this, right? It's how they're categorized. It's good stuff. It's easy to learn. They block the beta receptors, right? And then what does that do? It helps with all of these things here, but it basically improves the myocardial oxygen requirements, right? Because those are reduced, and these are all the different things the benefits that they exert. Uses, it mentioned, so typically in combination with other things, but they can be used for angina, so usually with the nitrates. And you'll notice here that they are advantageous to be given, so it's like a symbiotic relationship, right? If you give it with the nitrates, because they help reduce tachycardias. And then the other uses described in other lectures, I need to delete that, but don't worry about lecture 5. This is not necessarily... This is an old number, so just scratch that out. And the take-home point is that you have seen these in other lectures, so antiarrhythmics and antihypertensives. Calcium channel blockers, another one too. Just take this out. All right, movie magic there, right? Just that disappeared. It's magic. No, but yeah, sorry. I used to do things in a little bit different order, whatever. It doesn't matter. Mechanism of action, again, you guys already know. Calcium channel blockers, this is what they do. They block the calcium channels, and that is also how they're categorized, so that helps. And then these are the benefits of why they are helpful. They also help with, coronary artery disease, CAD, angina, that's what we're treating here, and then you guys already know hypertension and arrhythmias, right? Adverse effects, you guys have seen these already too, but CNS adverse effects, dizziness, flushing, lightheadedness. Hypotension, again, is a concern, which you guys would probably remember from the other lectures. So if you want to add that too here. The constipation, remember too, especially with verapamil. And then edema is one too that you have to be worried about. But these are just common adverse effects. And students in the past have asked me, hey, this isn't exactly what you said for the adverse effects in the antihypertensives. Really, you have to, so for testing purposes, it's all fair game, right? Any of my slides, any of my tables, no. But then for a real world kind of practical or pragmatic, what am I trying to say here? So yeah, for a pragmatic approach to when you actually practice medicine, you're going to have these categorizations and stuff, and then adverse effects, you can just go ahead and blend all these adverse effects and just add them all. Sometimes I make a bigger deal about certain adverse effects because of the lecture. So when we're talking about antihypertensives, there's certain adverse effects you need to be talking about more, just because of those patients that you're giving those medications to help reduce their hypertension, and the setting that you may be giving it to them, the duration you're giving it to them. Because I don't go into dosing here with you guys, but depending on the indication, so that can affect the dosing. So verapamil, for example, how you dose it for hypertension may be a little bit different than how you dose it for its antianginal properties. In addition to, are you prescribing it IV? Are you prescribing it PO? Is it inpatient? Is it outpatient? Who is the patient? Sorry, that was a bad pharmacist joke there. But yeah, inpatient, outpatient, and then the specifics of the patient, not who is the patient. And this is one that's by itself. You guys haven't seen this one before. The brand name for this is Renexa. And the reason I say that is because that's mainly what I've heard it being called, but this is an anti-angel agent. And you notice too, it's listed as a miscellaneous agent, just because of its uses and stuff. But anyways, its main use is the treatment of chronic angina. Again, that's the specifics. I put the guidelines in the goat lines. No, not the goat lines. The guidelines in here. So definitely go ahead and look through that, read through them, and so you can see when it would be appropriate to use or not. Mechanism of action. So this is a big mechanism of action here. Big mechanism of action here. A lot going on. Read through it. It's not fully elucidated as far as there is some uncertainty a little bit, but this one is hard to pare down to kind of whittle down to one thing like the beta blocker. But it is anti-anginal and anti-ischemic, and it does not have an effect on heart rate or blood pressure, which can be advantageous again depending on the patient, etc. But unfortunately, this is one of those mechanisms of action. Just go ahead and read through the second, and I think the second bullet point does a pretty good job of explaining what it does and how it works. And then I don't have a slide on it, but as far as adverse reactions go for this medication, usually well tolerated. More commonly, you have to be worried about some cardiovascular adverse effects, so things like bradycardia, hypotension. It's another one with hypotension. And you'll notice here, because of this last step in the mechanism of action, you do have to be concerned about the prolonged QT interval. It's one of those rare but serious adverse effects, and especially at higher concentrations, higher doses. So please note that. And then again, especially in combination with other drugs. There's also some CNS adverse effects, so dizziness, headache, that you may have to be worried about. But other than that, it's usually well tolerated. And then the last two things to note about this drug is that it does have the potential for drug interactions. So it goes through the CYP3A pathway. So you have to be worried about drug interactions with this one, so definitely note that. And then the other thing is too, on the Beers criteria, so with elderly population, you're supposed to use it in caution with patients that are greater than 75 years of age, because they're at more of a risk to experience those adverse effects and negative adverse effects specifically. Summary table here. Again, I always like this. Make sure you look at it. Make sure you squint at it. Adverse effects and contraindications. Next is a big section here. It's kind of a big section within this other cardiovascular drugs. And so this is things that will help with cholesterol, right? So hyperlipidemia, hypercholesterolemia, those are synonyms, right? So high cholesterol in layman's terms. So as always, make sure you note the categories. And well, I'll notice one thing with the categories here with the HMG-CoA reductase inhibitors. Also go ahead and put there /statins. That's another category that you will see, and that part of the reason I want to add it is that because it is commonly referred to as statins. So you can go ahead and just put a slash and write there statins as well. General considerations. So this is going to be review from ICM probably and pathophys, but just bear with me. Don't stress too much about this, but just know that there's, high cholesterol is a big issue now in the US and a lot of developed countries, but it's something that can sometimes be genetic, and so sometimes it's just, kind of no matter what the person does or how their lifestyle is, etc. And so that's called primary. And this is just definitions. So just read through these and just just kind of review for pathophys. And here's just a summary of why high cholesterol is bad. So over time, it just basically is bad. It causes pathology. And again, you guys will get that a lot in pathophysiology. Therapy. So this is going to be like the antihypertensive. First line, pharmacists were kind of bored, right? Because there's no drugs. No, first line is just diet and lifestyle modifications. So these are the TLCs, therapeutic lifestyle changes, TLMs, therapeutic lifestyle modifications, a lot of different abbreviations or whatever. I guess, yeah, people don't like to ever say anything out, in healthcare, they just like to use the abbreviation. But so TLCs is one that I hear a lot. But those are things that I believe you'll be getting more in your ICM courses and maybe a little bit in pathophys. But first line treatment. So, and I've already been through my little spiel about what I think are good lifestyle modifications for hypertension. A lot of those are applicable here. So, moving more, eating less, stopping smoking tobacco. Again, that's kind of the generic advice or, general advice that I think is good. And then second line, and why we're all here today, is the drugs, right? First, we have a niche group that is used. It's not super popular, but it's still out there, and there's some rationale, and you will see these being prescribed. But these are the bile acid binding resins. These, you can think of them as being very sticky chemicals, or that's the way I like to think about them as far as mechanism of action. But then they actually will they bind to bile acids, and they form these insoluble complexes that end up being excreted. And so this basically has a couple benefits, right? And so this helps to increase the conversion of cholesterol to bile acid, which so then lowers cholesterol. And then it also increases LDL receptors. So LDL is, again, probably a review for you guys, but is what is known as the bad cholesterol, which don't say that. That's saying a lot in lay public, but sometimes physicians or other healthcare providers will look down upon you. But so definitely with the lay public, you can mention that. But in a medical setting, we're talking to other healthcare professionals, specify LDL or whatever. But and then because there's also total cholesterol too, and so just to make sure you're. But take home point is that these help lower cholesterol levels. They're not, like I said, the best. They're not the greatest, but you still see them prescribed, and there is still some use for them. But as far as decreasing cholesterol, not maybe the best choice. Here you go is a visualization of, here's where they're called resins here on this chart, but they basically, this is where they're exerting their effect. And then we'll notice some other drugs that we will talk about later that, so for testing purposes for me, don't stress about memorizing this table and memorizing these steps and everything. I believe in pathophysiology, some of this may be relevant or may be testable material, but for me, don't stress about this. Just to be an aid and maybe help you with memorizing the mechanism of action. Uses. So these do need to be given with each meal. And like I mentioned, they help lower LDL level. It has a note there in combination with other drugs. So yeah, these are typically aren't first line, and it's typically an adjunct, and it's added later, added later on in combination with other things, just to kind of maybe nudge. Like, so you're on another cholesterol lowering medication, and this will just maybe kind of help nudge that. Interesting too. So, and then read through these uses as well. And then note too, depending on the specific genetic type of familial hypercholesterolemia, these may or may not be effective. But they also, like I said, they are sticky. So these can be used sometimes to help with toxicity. So specifically with digoxin toxicity. So, and again, it's just basically, it's a sticky molecule. So it helps bind to the digoxin so that you end up excreting it in your feces, right? And then it can also be used for the C. diff toxin, right? We talked about that a lot in the antimicrobial, but same idea there is that it's sticky, so you will see it being used there too, because it helps stick to the toxin, and then so the person can poop it out or excrete it, right? Adverse effects. So GI, put a big GI on this slide. GI adverse effects, definitely most common ones that you have to be concerned about. Constipation, nausea. So everything you can think about as far as GI. I put nausea and constipation on there too, but also cramping, abdominal pain, bloating, dyspepsia, too, vomiting, heartburn, flatulence. Flatulence is one that it's bad. People complain about it. People that are related to the patient taking it complain about it. This is one where people come into the pharmacy and they're like, what's wrong with me? Like, is this the drug? Please tell me, because if I'm smelling like I've never smelled before. But so anyways, that can also affect compliance. All joking aside, I am a professional, so I don't laugh when the patients come and tell me these things, but there's been a couple of times. One guy in particular, he was really funny about it too. He had a really good sense of humor about it, but he was just saying, like, if it smelled like something crawled up inside of him and died, but so that always sticks to me in my head. And even now I still laugh because the guy was like, yeah, but anyways, and you'll get those patient stories, and that they'll stick in your head because it's like their patient was just so funny or whatever. And you're trying to stay professional, and it's just. But anyways, so GI. Please note that those are common adverse effects. And then the other thing you have to be worried about is drug interactions. And so these actually can affect the absorption of other drugs. So you notice the list there. Please take note. You notice warfarin's on the list, right? And then also vitamin K's on the list. So definitely there's implications if a person needs to be anticoagulated, right? And so that's something that definitely want you guys to note, because as far as drug interactions, and then also too with some of these other things too, like if it's the iron or whatever. I mean, what other does the person have an iron deficiency, and then this maybe medication is making it worse, or on a antibiotic, and then are they not getting treated properly because of that? Also, you guys need to start making these. The application is what they call it. So you kind of apply, it has an adverse effect. It can cause malabsorption of things like vitamin K. So then a patient who needs to be anticoagulated, what are the implications? Or a patient who needs to be treated for the antibiotic, what are those implications? Do you stop the medication? Do you pick another antibiotic? What, I don't know, I'm asking you. No, I'm kidding. But you have to start kind of thinking of the full clinical picture. Next, we have the statins. So I added on this slide, but they all end in Statin. Very popular drugs, prescribed a lot. You will probably see these day one. No, probably pretty early on your rotations if you don't have healthcare background. These are ubiquitous, right? HMG-CoA, which stands for the 3-hydroxy-3-methylglutaril coenzyme A. So my testing purposes, categorization, just know them as HMG-CoA reductase inhibitors, and then also know them as statins. And this is also going to come into play with their mechanism of action. I'm kind of jumping ahead here too, but it's one of those nice drugs for pharmacy students in that the category is the mechanism of action. So take home point for mechanism of action is that it is an HMG-CoA reductase inhibitor, which is an enzyme, and it's the rate limiting step in cholesterol production. So we're going to get to that here in another slide, but I just want to mention that because it's nice for studying purposes, I feel. I have the generics listed here. I will go ahead and I'm going to say the brand names here. And again, just because you hear these, you hear practitioners refer to these as their brand names a lot. So number one, we have the atorvastatin, which is generic for Lipitor. The fluvastatin is Lescol. Lescol, Lescol, Lescol. The lovastatin is Mevacor, Mavacor. Pravastatin is Pravachol. Rosuvastatin is Crestor, which is really popular. And then the simvastatin is Zocor. So again, not on my test, but you probably wouldn't hurt to make a note of it if you don't have a healthcare background, just because you will hear those names. And the brand names don't have statin in it, so it's, maybe easier to remember the generic name. Mechanism of action, I talked about this, but it's that rate limiting step, right? So therefore you have a decrease in cholesterol. And here's the visualization again of where they specifically are working. So in addition to lowering their LDL, they have some other benefits here. I want you guys to read through those, but they can help cause some vasodilation here because they cause production of NO. They help increase plaque stability, so that's related to the C-reactive protein, and so that can be good too to help so you don't throw clots, right? Help with the atherosclerotic plaques, and then decrease platelet aggregation. Uses, so they help treat dyslipidemias, and they're also used for cardiovascular disease. So go ahead and read through those. And this is part of the reason why they are prescribed so much. So, and then as far as what they're used for, definitely pay attention to this, look through all these. I want you guys to make sure you know all of these. Put a star by this slide. But as far as its effect on cholesterol, sometimes students have had issues with this, but because it does so many different things, but it helps decrease total cholesterol, so decrease TC, decrease LDL, decrease the apolipoprotein B, but don't worry about that too much because that's just is a component to build more cholesterol, and then decrease triglycerides, TG. And it also increases HDL, which is known as the good cholesterol, right? And again, don't say that, but anyways, or with other healthcare practitioners. But so it does a lot of different things. It's kind of a grab bag. But if you are just trying to do one of those things, like, so for example, if you're just trying to increase HDL, you maybe can go with something else, like something like niacin maybe, or if you're just trying to decrease triglycerides, because that may be the specific thing for a patient, you could go with something else like the fenofibrates, which we'll talk about in a little bit. And so you have to kind of tease that out. But so kind of globally, statins are good. And this is, again, a big reason why they're used so much, because for most people with cholesterol issues, they have the issues with their whole lipid panel. So, and the lipid panel is just when you take a blood sample of the patient, and then you get a reading for their total cholesterol. It's usually fasting blood sample, and you get their total cholesterol, LDL, HDL, TGs, and then you can kind of see. But anyway, so just because there's board questions that will ask you specifically about certain labs or certain, like HDL, let's say. And so different things you can maybe do for that. And then there's some that, ask about triglycerides specifically. So anyway, so hopefully that's helps you guys, but definitely put a star by this and make sure you guys know all of the uses, and why it is prescribed so much. More uses here. So they also are beneficial if a person has, the genetic predisposition to, hyperlipidemia. One note here, and let me see, I'm going to jump ahead a little bit. Yeah, okay, so one note here, and this is where prescribers and then patients can get into trouble, is that the pregnancy category of statins. So these statins are contraindicated in the use with pregnant women, and so it's typically not an issue, because usually, and again, just making kind of a generalization or stereotype about patients with high cholesterol, it's typically a older person's disease, so to speak. And it's so high cholesterol for women is usually when they have passed their menarche or they are no longer fertile. And so you can prescribe the statin and it's not an issue as far as, but if a woman has a genetic predisposition to having hyperlipidemia, this is where it gets into an issue. And so if you are going to prescribe a woman of childbearing age or whatever, that you do need to make sure she has a that she's knows about the pregnancy contraindication, and that she is if she's in a sexually active relationship or whatever, that she needs to be on contraceptives. And they actually recommend 2 is kind of the safest. So 2 forms of contraception in combination. And we'll talk more about the specifics on the contraceptions and which ones are better than during the OB-GYN module. So don't stress too much about that and having to worry about looking that up or whatever. We're going to definitely spend a lot of time on that. But please note, and it comes up, and so it's like kind of classic board question. The person has, it's this genetic hyperlipidemia, and it's a younger woman, and so you have to be thinking about the pregnancy implications, right? Because she could potentially get pregnant, and these are contraindicated in pregnancy. Related to that, we have some adverse effects. So elevated hepatic enzymes. So this is why you need to monitor the liver. So this is why they require a baseline LFT, which is a liver function test, because they can cause elevated hepatic enzymes. A lot of times it's not an issue. It is kind of a rare but serious one. It's not something that, but it is common enough that they do recommend that you get that baseline LFT. And then also related to that too, you do need to use in caution with the patients that consume large amounts of alcohol and or have a history of liver disease. So again, that can be something, potential implications. And then just so you guys were on the same page, kind of textbook definition, for men, it's, or it's recommended to have 2 drinks of alcohol, and it's like 2 12-ounce beers kind of thing, or I forget how many ounces of wine, but and then for women it's 1, so 1 12-ounce beer. So again, make sure your patient isn't a heavy drinker, or large amounts of alcohol is consumed by your patient. Another rare but serious one is the rhabdomyolysis, or the muscle pain, so skeletal muscle toxicity. So also known, and they also maybe refer to it as myopathy. So again, rare but serious one. And this is something that we typically will describe as an unexplained muscle pain or weakness. And so this is not something if the person is working out at the gym and they're sore the next day from lifting weights or whatever, or mowing the lawn or doing something like that. It's it's like I didn't go to the gym and I have this muscle pain, muscle weakness, uncomfortableness or whatever. So it is something that, it's more likely with the higher doses. And so, but again, overall rare, but it is something that you need to be concerned about, and definitely something to note. And it can be a reason to discontinue the medication. And then the recommendation for the patients should always be instructed to report unexplained muscle pain, unexplained tenderness, weakness, and then brown urine too can be a sign of that. So those are all things that the patient should be instructed on. And usually in the pharmacy we educate the patient on that. But it doesn't hurt for the prescriber to or when your follow up too, because sometimes it's like we give the medication, we tell them, hey, this is, watch out for any unexplained muscle pain or weakness. And then you guys follow up with them, right? Because you're monitoring them for their cholesterol over a longer period of time. It can be something part of the follow-up, like any muscle pain or weakness or anything, on kind of out of the norm. Other than that, usually well tolerated, don't have a lot of problems with it. As far as common adverse effects go, you can, headache is one that people complain about, or dizziness. Some GI adverse effects as well, or can be common. So constipation, nausea, not super common, but again, some people complain about that. Edema is again one, and AFib or atrial fibrillation is one. And the AFib can be up to 6% of patients that take it. So that could be something to think about here. And I think, that's my last slide here. So I'm going to make sure I also wanted to talk about, drug interactions. So this is one. So they don't recommend using the statins in combination with strong CYP3A4 inhibitors. So those are things like, I don't know if you guys remember, we talked about the azole, antifungals, erythromycin is another example of that, of a 3A4 inhibitor, not an azole. So ketoconazole is an example of an azole. But anyways, and so you do need to be thinking about drug interactions. It typically isn't a huge deal. So I do come across quite a few drug interactions in the pharmacy with the statins. Part of it is because not everybody, but a lot of patients are on the statins. So, and then they'll get an infection and they need to be prescribed clarithromycin or something. So typically the strategy is they'll discontinue the statin for the week that they're on the antibiotic. And there's not really too much of a concern. And then also related to the drug interactions is grapefruit or grapefruit juice. So again, you'll hear about this, and this is something that you'll see in textbooks and sometimes on your boards and stuff. But and then in South Texas too. I mean, I guess old people love grapefruits, right? No, but that's a stereotype. I'm sorry, old people that like grapefruits. My grandparents love grapefruit, so I've always had that stereotype of, and then especially down in South Texas, but. So the grapefruit juice is a CYP or a CYP, the P450 inhibitor. So it can cause increased levels of the statins. So you have, anytime you have that drug interaction, increased levels of the statins, because it's not being metabolized properly, you have an increased risk for adverse effects. So these rare adverse effects here, like the liver damage and skeletal muscle toxicity, can be more pronounced. And so if you look at textbook medicine and then the handouts we give at the pharmacy, it says to avoid grapefruit juice. But I've had patients that, still like it or whatever, and they want to drink a little bit. In pharmacy school, we were taught that they're not sure exactly how much grapefruit juice ingestion will cause the problem for the patient. And it's really going to be patient specific. So for textbook medicine, definitely know that it is, should be avoided. But then out in practice, it's just going to be, it is really patient dependent. And so it just kind of depends. Like if there's someone that just really has to have like half a glass of grapefruit juice and they're on a lower dose of a statin and they haven't had any issues with it or anything, and they don't have any adverse effects, I might say, oh, that's okay, or whatever. But definitely for testing purposes for your board exams, know that it is a drug interaction, and you hear about, for some reason, I feel like you hear about it a lot, just like in the media, like on the news and stuff, people talking about, I guess because it's grapefruit juice, so it's kind of exciting that like something you can buy at the store could kill you, I guess, I don't know. Like grapefruit, is your grandma drinking grapefruit juice with her cholesterol medication tonight at 5? I don't know. Grapefruit juice is killing granny. I don't know. There's just, maybe that's part of the reason it's so popular, but so, because I've had students ask me about this in the past. So yeah, textbook, it is a drug interaction. It is something to be avoided. But then out in practice, in reality, if a patient comes to you and they're just like really like, I gotta have my grapefruit juice, of course, patient specific, it's going to depend. There is a risk, right, of increasing the levels of the statin. That is documented. I mean, it is something, but it's one of those that's maybe not as severe as they initially thought. And but anyways, so yeah, so hopefully that's clear. So textbook for testing purposes, grapefruit juice is a P450 inhibitor, so it increases levels of statin, so increased risk of toxicity, adverse effects. But yeah, you'll come across a lot of citrus heads in the valley, right? In this South Texas. All right, switching gears here a little bit. We have the fibrinic acid derivatives and niacin. So these are collectively known as the lipoprotein lipase stimulators. So for testing purposes, know their subcategories too, because niacin it's in the same category, but it is different enough than the gemfibrozil and fenofibrate. I want you guys to keep those separate in your notes, etc. All right, so first we have the mechanism of action, and these, just for clear, just so everyone's on the same page, these is the mechanism of action for gemfibrozil and fenofibrate. I've had students in the past and think that I was talking about all three here. So we're first talking about, this is mechanism of action for the fibrinic acid derivatives. So hopefully that's clear for everybody. I felt really bad last year. Someone got confused And anyways, but yeah, so feel bad about that. Don't want people to make that same mistake again. But so this is for the fenofibrate and gemfibrozil. And this is, they basically activate the PPAR alpha. This is the little a stands for alpha there. But take home point is that they lower triglycerides. So they are preferred. I mentioned earlier that there are some drugs that are preferred. So if you want to lower just triglycerides, these are going to be your preferred drug of choice, number one. So the statins have a positive effect on triglycerides as far as lowering them, but they're sometimes, depending on the patient, if there's a drug interaction or the patient can't take it. So let's say the patient has that rare but serious rhabdomyolysis with the statin, and you want to still lower the triglycerides, then the fenofibrates would be the way to go. And you'll notice here use is because they're used for hypertriglyceridemia. So the hypertriglycerides. So, and again, this is second line. So if they failed dietary interventions, then you can go to that. Adverse effects. So the muscle pain there is still there. Not as big a concern as with the statins. These can aggravate gallbladder disease, so they are contraindicated in that. And then they sometimes can increase LDL, so that may be something that's undesirable, again, depending on the patient. But niacin, so this is, again, mechanism of action for niacin. And this is also known as vitamin B3, so you may hear it being used as that, so you can add that too if you'd like. And it has some different brand names too that sometimes people refer to it as, but sometimes people will refer to it as, or other practitioners refer to it as vitamin B. So as far as the mechanism of action goes, so the mechanism by which niacin affects plasma lipoproteins is not fully understood, or it's not fully elucidated. So they're not really sure. They have an idea of a few things what it might do, but it can reduce total cholesterol some, and have some other benefit effects. But its main benefit is, or its main use is to increase HDL. So that's it's. But read through everything else, and like I said, it's vitamin B3, so it is a dietary supplement. It can be used for pellagra, too. But excuse me. But yeah, so main benefit is that it can increase HDL, which is the good cholesterol. So this, again, if you were wanting to target just HDL, then this is its number one use. Adverse effects. So niacin flushing is a thing that patients hate. So again, super annoying. Patients don't like it. Unfortunately, can be common. But it's this itchiness, swelling. It's just like a really bad, like, I don't know if you guys get embarrassed and blush, but it's like, blushing really bad in face, neck, etc. Definitely pay attention here as far as these are some strategies to help mitigate that. So one strategy is you can take an aspirin 30 minutes prior to taking your niacin. You can also take niacin on a full stomach. That can also help reduce the flushing. And then they also make a extended release formulation. So Niaspan is one because it spans the whole day. I don't know, it spans the universe, but Niaspan is extended release formulations, and there is decreased risk of flushing there. Oh, and I've had students ask me in the past, but it's aspirin. It's at 325 milligrams of aspirin 30 minutes before. You'll notice next it has increased hepatic enzymes. This is another one that can cause hepatotoxicity, unfortunately. More common with higher doses than lower doses. So typically they recommend starting with a low dose. So for example, extended release 500 milligrams at bedtime or QHS, and then to titrate up. And then you also need to be thinking about if there's other medications, like if they're also on a statin, and that also has hepatotoxicity, what are the implications there? So it's kind of like a drug interaction that you can think of too. Also related to the statins too is the myalgia. So again, maybe something that you have to be worried about there if the person's also on a statin. You'll notice that type 2 diabetes is on there too. So this is something that where niacin can increase fasting blood glucose. It's usually pretty modest. It's not huge swings in blood glucose, but it is something that, because of that, you do need to use this with caution if a person has type 2 diabetes. And then again, with the patient population, you need to make sure that they're monitoring maybe more frequently, and then they may need to adjust or alter their anti-diabetic medications because of the effect, or if they're taking insulin, for example, to help lower their blood sugar. That may be something to think about. The other one that's not on here too, as far as adverse effects goes, common adverse effects are GI adverse effects. So definitely put GI on here somewhere. And so GI distress, vomiting, diarrhea, things that they can be improved with, again, taking it after a meal, but it is still something that can be problematic for patients and cause patients to discontinue the medication. And then specifically too, if they have peptic ulcers, it can make that worse. And also another reason to maybe avoid this medication is if a person has peptic ulcer disease. I always have to practice this one. So this brand name is Zetia, Zetia, which is way easier for me to say, and usually people refer to that that way. Ezetimibe is how you say the generic name, and I don't know why I always get tongue twisted and like mix up the letters and Ezetimibe, but Zetia is the brand name of that. You got the mechanism of action there listed. So read through this mechanism of action, but it does a whole bunch of things. It decreases total cholesterol, LDL, ApoB, and triglycerides while also increasing HDL. So when this first came out, they thought this was going to kind of replace the statins. And initially it was kind of sold as that and kind of, marketed as that, etc. And so I have a note here about its use. So it's used in combination with some different things. And again, it's a lot here, but just go ahead and read through all that. But just take-home point now is that most current guidelines show that it shouldn't be used as monotherapy, and that it's something that it's now pretty much reserved just to be used in combination with statins. And it's for those who can't tolerate the higher statin doses, for example, the elderly population. So it's usually not prescribed monotherapy unless it's just there's like an absolute contraindication is where someone cannot use it. It is a little bit safer in pregnancy. It's not absolutely contraindicated, but it is. There have been some adverse events that were still observed in some animal studies. So it is contraindicated in pregnant women who require combination therapy with a statin because of the statin implication. And then they actually recommend using other treatments during pregnancy if a person has the familial hypercholesterolemia. So it's not recommended for pregnant women. So it's a little bit, it's the pregnancy category isn't as strong as the statins, but again, it's not recommended. It is contraindicated in pregnant women. And the reason I'm emphasizing that is because there's been students in the past that have thought that because it's not a pregnancy category X, it's a pregnancy category C, that it was recommended, but it's not. It's contraindicated in pregnant women, and so hopefully we'll avoid that confusion again. Good summary table here, and you'll notice too the Zetia, it has pregnancy and pregnancy. So for the statins and for Zetia, they both are contraindicated. So it was on, and that's basically what had happened. There was a test question about it, and the student had said that they had missed this table here where it said basically they didn't see that pregnancy was listed for the Zetia as well. But look through this, definitely go clinical applications, adverse effects, contraindications, all good stuff. I included this table too. I like this one. Don't stress too much about memorizing it per se, but it's it maybe help you more on rotations. And actually, there's a student on her rotations right now that asked me to provide this for her because she thought this was beneficial. So this may help when you're more on rotations, but it has all the statins listed here. And also note too that, oh yeah, so this will just show you with drug interactions that may be beneficial. Also note too that there's the pitavastatin, which is the brand name Livalo, Livalo, Livalo. And this is the newest one, and just go ahead and add that. That wasn't on my previous slides, but please include that with all of your statins to make sure you guys are most up to date. But that is the newest one. You notice too with the time of administration, I didn't mention this, but some are dosed at bedtime, and the idea was that the majority of your cholesterol production is done when you're sleeping, and so that would help block that cholesterol production. But now with you'll notice that too. That's with this, the Zocor is mentioned there. But then you've noticed they've come out with some extended release products here for the fluvastatin and lovastatin, and you can take those anytime. And then the half-life for something like pravastatin or rosuvastatin, you can dose it anytime. So you can dose it in the morning if it's more convenient. So anyway, so you may hear some people say that you can only dose statins in the evening. That's kind of historically that was thought to be best, but now it's going to really depend on the preparation of, so if it in the specific statin. So if they are talking about simvastatin, yes, dose that at bedtime, but then these other statins you can dose at other times. And then we have another table here that I like a lot. This is for lipid lowering agents, so definitely make sure you look at this and pay attention to this slide here. It has the dose and dosaging, which isn't, don't stress too much about, but may be beneficial on your rotation, so you might want to hold on to this. And then major side effects and drug interactions. And if you guys can probably tell, they're stamped. These are both from Up to Date, so if you have trouble reading these, or if you want to find them or look at them, or whatever, or read more about it, you can pull these off of Up to Date, or email me and I will get you a copy of these. But I like this area too with the major side effects and drug interactions, so I think it'd be beneficial for you guys to look at those. All right, this next section here, drugs for heart failure. You're going to notice that we've talked about a lot of these already. So a lot of this is going to be kind of repeat, and I'm going to go through kind of quickly just because you've seen a lot of this already. ACEs and ARBs, we've talked to those before. They are good for hypertension, but they can also be used for heart failure. Beta blockers, list there. Again, we've talked about those in a few different sections now, but also beneficial for heart failure. So read through this. And then note 2, carvedilol is actually mixed. It's an alpha and a beta blocker. And this is one that can specifically be beneficial for heart failure. Diuretics, another one we've talked about, especially the loop diuretics. They're very good at getting rid of fluid, and basically heart failure is when you have too much fluid, or you need to get rid of your fluid. And so those loop diuretics are good, and they're usually better than the thiazide diuretics. But so not all diuretics are, so this is where things like furosemide would come into play. Vasodilators, again, read through this list. We've talked about them before, but just know that vasodilation may be part of your strategy for heart failure. These we have not talked about. A couple of phosphodiesterase inhibitors, just look through this, but they're not used a lot because of long-term uses associated with increased morbidity and mortality. Don't really see these being used anymore. Positive ionotropes. So these all increase force of contraction, so that's good if you have a weak heart, or if you need help there. Now we have the beta agonists, so a couple listed there, dopamine, dobutamine. They are actually agonists, beta-1 agonists, so they stimulate the receptors and they cause the heart to beat more, so those are used acutely. Digoxin, so this one is, talked about this one a little bit because it is a antiarrhythmic agent. So it can be used for AFib, and then it's also used for heart failure. And this just has, it's from the foxglove flower, just FYI, the digitalis flower, but don't stress about that. Mechanism of action, it basically increases contractility by inhibiting this sodium potassium activated ATPase. So it inhibits the ATPase pump in myocardial cells and results in a transient increase of intracellular sodium, which in turn promotes calcium influx via the sodium channel exchange pump, and then that leads to increased contractility of the heart. So it helps increase the pumping of the heart. And this is just basically where it was working. This is what I was saying, or rather, a visualization of what I just said. So, like I said, it's used for AFib, a flutter maybe, so related to antiarrhythmics, but then it's also used for heart failure. So it's used for the treatment of mild to moderate or stage C, as recommended by the ACCF, AHA, heart failure. So it's mild to moderate heart failure in adults, And then sometimes it can be used to increase myocardial contractility in pediatric patients with heart failure too. So you may see that. But just note, for the treatment of AFib, it's not considered a first-line medication. And digoxin may be considered for rate control in patients with heart failure with reduced ejection fraction without pre-excitation or in sedentary patients. So it's kind of a niche use there. So not first line for AFib, but may be beneficial for rate control in patients with heart failure who also have reduced ejection fraction. Adverse effects. So definitely put a star by here. You do need to be concerned about the digoxin toxicity. So this is a potential problem with this medication. So the digoxin toxicity is usually associated with digoxin levels that are greater than 2 nanograms per ml, but there can still be symptoms at lower levels. And then patients that are an increased risk for digoxin toxicity include those that have a low body weight, and if they're older, or if they have quote-unquote advanced age. Also, if the patient has renal impairment, they're also at an increased risk for toxicity, so that's something to be concerned with. And in addition to that, patients who have hypokalemia, hypercalcemia, or hypomagnesemia are also at an increased risk for digoxin toxicity. So you have to be worried about that. But definitely look through these signs and symptoms of the digoxin toxicity. And as far as the treatment of toxicity, you definitely want to DC the medication. And then, like I mentioned, if they have hypopotassium or they have hypomagnesemia, definitely want to correct that. And then please note too that you can give the digoxin antibody too. And then precaution here, I touched upon this already, that person with hypokalemia is at an increased risk for digoxin toxicity. And so just kind of, again, trying to connect the dots. If a person's on a diuretic, let's say, or something else that can cause hypokalemia, increased risk. So that's kind of a potential there for drug interaction. Good summary table here, so definitely look at that and make sure you study this as well. Another good summary table, so make sure you also look at that. And that is it for my presentation today. So as always, please feel free to email me if you have any questions or anything. Thank you guys for your time and attention. I appreciate it, and I'll talk to you guys later. Bye.